Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Feel free to ask questions in the chat box as we go along, and they'll be addressed. So today we're going to start off an introduction on endocrinology and hormones as we kick off our gastroenterology month this month of April 2024. So let's get into it. So today we're going to be talking about the endocrine system, just the basics, how glands work. Then we're going to be talking a little bit about how endocrinologists do their clinical assessments and also how we as future clinicians also do that. Then we'll also learn a few career facts about how to become an endocrinologist and the pathway to becoming one. And then finally, we'll have some case studies on diabetes and other diseases by Dr. Chima, all related to endocrinology. All right, so I'll be starting off and talking a little bit about the endocrine system and really what it does and what it means for us. So first, let's talk a little bit about how cells actually communicate. So basically, as you know, we have prokaryotic and eukaryotic cells. And prokaryotic cells are basically much more simple. And as you become more and more complex or more multicellular, does communication between cells become more complex as well? So for prokaryotic or unicellular organisms, the communication between how their cells or one cell communicates is much simpler to how our cells communicate because we are multicellular and eukaryotic cells. So communications between the cells for prokaryotic cells are much more modest than those required to maintain a multicellular organism. And that's probably why, they are more focused, or the prokaryotic cells are more focused on the ability to signal the presence of beneficial substances like food or toxins in the local environment. So that was much more local. But when you're thinking about the human body, this is the endocrine system. These are all the glands associated with it. There is as you saw from the top, the pineal gland, pituitary gland, which involves the posterior and anterior pituitary. Excuse me, the parathyroid gland, the thyroid gland, adrenal gland on the kidneys, that's what adrenal means. The pancreas is also considered part of the endocrine system, the ovary, and the testes. And also talk a little bit about more in terms of what each gland produces, because each of them produce hormones. But these are all the glands again. They're basically an endocrine gland. The actual definition of it is essentially a ductless glandular structure. So they don't have ducts, but they are glandular in shape, in form and shape, and they release hormones into the blood. So the classic glands that I already talked about are, involve the pituitary, adrenal, thyroid, parathyroid, the islets of Langerhans, which are in the pancreas, and also the ovaries and testes. But there are also non-classical glands that are considered, you wouldn't consider them to be like part of the endocrine system per se, but they do have some endocrine function. Like the kidney, it produces renin and erythropoietin. Adipose tissue, which produces leptin. The gut, as in the GI system, they produce incretins or cholecystokinin. The stomach has gastrin, and the heart also has these peptides as well. So we can see in this picture here how how an endocrine cell works, any of these glands. It has secretory vesicles that secrete basically molecules or hormones into the bloodstream. So that's a little bit different from what I'm going to talk about next, but essentially hormones, they serve as the chemical basis for communication between cells. And they're these signaling molecules that traffic information from one cell to another. So the classic hormones are communicate through the bloodstream, but they can also have local effects, like on a neighboring cell, they can have paracrine effects, and on the secretory cell itself, they can have autocrine effects. So in terms of autocrine and paracrine, I remember also learning juxtacrine when I was studying for my MCAT. So this is very high yield for the MCAT. You need to know the differences between paracrine, autocrine, and also juxtacrine. So basically, a paracrine hormone targets from one cell to another cell without touching. It's basically this, you can think of it as like a Wi-Fi network of how the cell releases molecules or hormones to a target cell to communicate with it. An autocrine cell is essentially a cell that communicates or targets itself. So it releases molecules, but they just target itself. That's autocrine. You can think of auto, automatic. So auto tends to be self or your own. So that's how I remember what autocrine is. And then juxtacrine is basically when the cells touch each other, and that's how, and that that basically triggers the transfer of the molecules. All right, so these are, there are a lot of hormones, so there are a lot of different, I'm a lot of different mnemonics to remember. So, for example, I remember this was very high yield for the MCAT, flat peg. Basically, that is a mnemonic that tells you basically all the hormones associated with the pituitary gland, the posterior and anterior pituitary. So basically, the posterior pituitary really just releases two hormones, oxytocin and ADH. Whereas if you think of flat peg, there are a lot of hormones released by the anterior pituitary gland. So it makes it easier. Like F is for FSH, L for LH, A for ACTH, a T for TSH, flat, and then peg includes the PRL, the prolactin, the endorphins, and also GH, the growth hormone. So hypothalamus produces ADH, oxytocin, and other regulatory hormones. We learned about the hypothalamus during Neurology Month. The pineal gland releases melatonin. The heart has the peptides ANP and BNP. And we talked about, the kidney and the gut as well, because they are considered non-classical glands. Same with adipose tissue. Adipose tissue is really just not necessarily an organ, but adipose tissue is fat tissue that also has hormones associated with it. The pancreatic islets of Langerhans, they release insulin and glucagon. And we also have the and the gonads. So for males, is that in the testes release the androgens, inhibin, especially testosterone. In females, it's ovaries, and the ovaries are producing estrogens, progestins, inhibin, and then also the thyroid gland. The thyroid gland involves thyroxine, T4, T3, and calcitonin. So overall, there is a lot to memorize, but each one, when we break it up, it makes it easier to remember. So, and last but not least, the adrenal glands, they're also very important. So there's adrenal medulla and adrenal cortex within the adrenal gland. We've talked about it before when we discussed pancreatitis in a previous teleshadowing session. But basically, the adrenal medulla produces epinephrine and norepinephrine, and the adrenal cortex produces cortisol, corticosteroid, aldosterone, and androgens. All right. So now there's this concept of homeostasis. Like, why did I talk about all these hormones? Why are these important? Because I remember when I was studying as a pre-med and on my MCAT journey, I just learned that. I didn't learn pathology or I learned the basic anatomy and physiology, but really I didn't, it's important to have that base and foundation in order to understand what can go wrong. So by knowing what's normal, that's how you can know what's abnormal. So basically, homeostasis is our body's way of maintaining its proper body temperature, staying healthy. That's usually a state of homeostasis. But when things tend to, when something, when basically I think of it as a scale. Like if the scales are not balanced, balance means homeostasis. And if they're out of balance, then that basically means that we are no longer in homeostasis. So we can think about balance in terms of the context of hormones. If we have too many hormones, that's a hormone excess, and that can lead to specific diseases. If we have a deficiency of hormones or hormones not being produced as they should be, let's say there's a tumor on your adrenal gland, so you're no longer able to produce the hormones that the adrenal gland produces, like the epinephrine, norepinephrine, or the cortisol. Or maybe the adrenal gland is overstimulated for some reason. So that for some reason, you also need to find out as a future clinician. But if it is overstimulated, then you are producing too much. So maybe it might be too much cortisol. So we need to try to maintain homeostasis in the treatment of our patients when it comes down to hormone levels. So as I was talking about, there are a lot of syndromes of hormone excess or deficiency. This is basically the backbone, I would say, in the foundation of endocrinology as a field. Basically, you have excess, let's say thyroid hormone, you will have, that's called Graves' disease. If you have too much cortisol, that's called Cushing's disease, and it could be caused by an adrenal tumor. An adrenal tumor could, push on a gland and cause it to become overstimulated and produce more cortisol, but that would be pathologic. In type 1 diabetes, there's a deficiency of insulin that's produced by the pancreas, specifically the beta cells of the pancreas. But that is an autoimmune, and so you want to know like what is the cause of that excess or that deficiency, and that cause would in this case of type 1 diabetes, we know now it's a autoimmune destruction of the beta cells that causes that deficiency in insulin production, which leads to the downstream effects and symptoms of a patient with type 1 diabetes. Another example of a deficiency in hormones is estradiol. Estradiol is basically the precursor to estrogen in females. And so if there it becomes, over time, females, we have menopause in mid late 50s, some earlier, some later, but that is what causes menopause when we have a deficiency in estrogen production. And in fact, I can think of some more as well. And now I'm thinking about like if, for example, the hypoglycemia, that's an example of excess insulin. So there could be an insulin secreting tumor that could lead to hypoglycemia because remember, insulin is what is used for basically reducing your blood glucose. So if there's too much insulin being secreted, then that means there's less blood glucose, and we need glucose, as you may know from all the Krebs cycle, from gluconeogenesis, glycolysis, metabolism. That's really the crux of how we function. Glucose is basically our currency because it translates into ATP and energy. So if we have an insulin secreting tumor, it would lead to hypoglycemia. And so that hormone that is involved there is insulin. Another thing I can think of, I guess, from the top of my head is like a deficiency, like it could be an adrenal insufficiency, and that could be caused by an autoimmune adrenal destruction, and that would lead to a decrease in cortisol being produced. So a deficiency in cortisol would lead to adrenal insufficiency, and then you can also learn about all the symptoms and downstream effects in medical school. In fact, you can also think about like a deficiency in testosterone, like hypogonadism. So that could be caused by like a suppression of GnRH by opiates or opioids. So if we have less testosterone, then that could lead to hypogonadism in males. There's also, parathyroid hormone. That's very important for calcium homeostasis. So if the parathyroid hormone is in excess, it'll cause hypercalcemia. It could be caused by a parathyroid tumor. Or if there's a deficiency in calcium, it could cause hypocalcemia. For example, there are some cases where patients need their parathyroid gland removed, and that will lead to hypocalcemia. And so their treatment, they would need to be supplemented with calcium supplementation. So now that we've talked a little bit about cell communication and hormones and examples of some diseases that are caused by hormone excess or deficiency, now we should try to think about like how do we differentiate between the communication of cells in the nervous system, like we talked about during Neurology Month last month, and the endocrine system. I think that's a really good thing to think about because you can see here, like the nervous system is actually on the left, the nervous system. It's just this wired system with specific structural arrangements between neurons and target cells. There's neurotransmitters that are released, whereas in the endocrine system, there are hormones, right? But neurotransmitters are released through the action, there's action potential involved and synapses, and they diffuse through a very short distance. Whereas in the endocrine system, which is a wireless system, there's no like actual structural connection with one another or target cells. Because once you're in the cadaver labs, you'll see that you're able to identify actual nerves. Nerves are the wires, you could say, of the nervous system, but there are no wires in the endocrine system because all the hormones are being transferred wirelessly through the blood. So because they're released and carried in the blood, they could also go long distances, whereas neurotransmitters can only be released through short distances. That's an important differentiation to make. In the nervous system, the response tends to be rapid and brief, whereas in the endocrine system, there is a slower and more lasting response. I would also say the nervous system coordinates much more rapid and precise responses, whereas like endocrine system tends to, I guess with the exception of the fight or flight response, um, um, it really does control activities of long duration, the endocrine system, like growth, reproduction, metabolism, like the electrolyte and water regulation and ADH and with the kidneys. So I would say the endocrine system is, of course, very different to differentiate from the nervous system, even though they're both involve cell communication, intercell communication. But you can see there are no wires between the endocrine system, whereas, the nervous system does have nerves and wires, or you could call them wires, but they're nerves. All right, so now switching gears a little bit into the clinical assessment. So let's say you are now, in your first or second year of medical school, and you're rounding with your attending, or in your third year clerkships and your internal medicine rotations, or just overall any clinical assessment. If you're suspecting an endocrinology pathology, you see like any things that might tip you off. These are basically the things that you have to do. First, you start off with your basic history and physical exam. Of course, the labs are involved. The baseline laboratory tests include the clinical chemistry like A1C and glucose. Now, A1C is very important because really the bread and butter of endocrinology cases are mostly diabetes, especially in the United States. Also globally, there is a global obesity epidemic. Um, Also, the hormone blood levels, like you can actually check for hormones like growth hormone, T4, thyroxine. And also another way you can check labs is through a urinary excretion of hormones. So you can actually assess for free cortisol if you're suspecting like an adrenal insufficiency. You can also do dynamic testing. And what I mean by dynamic testing is basically you can do stimulation tests or suppression tests, which I find very interesting. So basically how these tests work, I can talk about it very briefly because I didn't have a slide on this, but basically you can measure hormones. Basically, it really depends on the time of day because cortisol levels they peak in the mornings. But dynamic testing is basically stimulation tests and suppression tests. So stimulation tests basically assess your body's ability to increase secretion. So that's used to test for any hormonal deficiencies. So if your body is not able to produce something but you're artificially stimulating like a specific gland, um, you can see if the gland is producing it normally. So for example, if you can actually administer like synthetic ACTH to determine like whether the adrenal glands can secrete cortisol on a maximum level. So for a patient who has adrenal insufficiency, if you do a stimulation test, you might find normal labs, but that doesn't mean that that's not normal, right? You're not expecting to see normal labs for someone you're doing a stimulation test on. So that's how you can also add it to your differential and sort of investigate further for a hormonal deficiency. Because if you are stimulating a healthy person's cortisol, they should peak in their cortisol levels. It should be a higher level on your lab values, not necessarily a normal value. So even if you see a normal value, as an endocrinologist, you know that that's not necessarily always the right thing. And then suppression tests, basically in the dynamic testing world, they assess the body's ability to decrease secretion. So they're used to basically test hormonal excess. So you're able to actually give synthetic like corticosteroids to try to suppress ACTH and then lower the amount of cortisol secreted. And so if it lowers appropriately and it goes below the normal lab value range, that means you're good, you're responding normally as your body should. But if your body's cortisol remains normal, then and despite trying to decrease that cortisol level, then that means you have an excess, right? So it's very intuitive when you get into it. And you think about, I'm just giving an example of cortisol now, but there are very interesting ways that we can actually test for these things in our patients. And finally, you can do localization of abnormal glands or tumors through imaging studies like an ultrasound, CT, MRI, wherever indicated. You can also do angiographies and venous sampling. And there's also a newer field in nuclear medicine where you can do a lot of radioiodine testing to assess like the thyroid gland, for example, to assess basically its function, if it's functioning properly. All right, so I was talking about the history and physical exams. I wanted to also give you a visual. So you can see on the right here, basically in Cushing's syndrome, you would see these purple striae. And remember, Cushing's syndrome, we talked about before, it's too much or an excess of cortisol. In Graves' disease, you would expect a ophthalmopathy, which basically means an enlargement of the eyes. That is pathologic. So if you see these signs, then you can also add it to your differential diagnosis. There's also acromegaly. Acromegaly basically means that there is an excess growth hormone being produced within the hypothalamus. We know that there's the pituitary gland. And so if there is, like, for example, like an adenoma, pituitary adenoma, basically a pituitary tumor, it may overstimulate or produce excess growth hormone, which would prominently be an acromegaly manifestation, which would lead to like a prominent chin and jaw that you would see on your patients, and also some large hands. All right, and let me next slide. Yes. So now let's talk a little bit about career facts in terms of endocrinology, how you would be an endocrinologist if any of this interested you. So basically, after medical school, you would pursue 3 years of internal medicine or pediatrics residency. You can be either a pediatric endocrinologist or or a adult endocrinologist. There are other ways to also get involved with endocrinology. You can, go take like a neurosurgery route if you want to just focus on pituitary tumors and removing and resecting them. There's a lot of different fields where you can have like an endocrinology focus, but specifically endocrinology, the management of these hormones. After internal medicine residency, you pursue a fellowship or a subspecialty in that. That's usually 2 years, but it can become 3 years if you would like to add on a research year. That's what the third year is usually reserved for. And as I talked about before, about 50, every specialty has its, I guess you could say, bread and butter. So for endocrinology, most of the cases that you will see when you're managing as an endocrinologist are roughly like half of them, half your cases will be diabetes. But if you go into academic medicine, you work in tertiary care centers. What I mean by tertiary care is basically an academic center. You can see much more complex and different cases. And you can also choose to specialize if you don't want to do diabetes. You can also, become an expert in a specific type. Like you can work on just, the parathyroid gland or the thyroid gland or really anything in more complex areas. But most of the time you are managing diabetes. It is the most common case in endocrinology, or what an endocrinologist usually sees. Now, I did also want to touch very briefly on the endocrinologist shortage as well in the United States. Yeah, there we go. So basically, this is a map showing you that now panel A and B are for adults over the age of 18, and then panel C and D are referring to pediatric populations. And so essentially, the first map here in panel A is talking about a 20-mile buffer. So basically, they're assessing the the percentage of adults over 18 that had access to an endocrinologist within 20 miles. And you can see here in dark, they have more access, but in light, they have very little, like about 37%. This is what the light blue means. Whereas in dark blue, you can see in the East Coast, sure, they have within a 20-mile buffer, but for people who have transportation issues in rural areas, even in these East Coast states, there are still some issues, accessing endocrinologists, especially as the number of cases as diabetes increases in the United States. So yeah, and same with pediatrics. While there are more endocrinologists, there are more in a 50-mile buffer, and when you see on the right panel here. But 50 miles is not necessarily very accessible to a lot of people, especially living in rural areas where there isn't public transportation. So even 20 miles is a lot, but you can see here, I mean, in the 50-mile buffer, yes, there are endocrinologists, but there need to be more. So I definitely encourage going to endocrinology if you're interested in it. Right. Now I will pass it off over to Dr. Chima. She'll be going over some case studies with us related to some of these endocrinology cases we discussed. All right. Thank you so much, Dr. Chima, for your time.
Good morning, everyone. Thank you, Pinahil. I really appreciate. So we went over briefly the anatomy and the function of the hormones. And I really appreciate we have two students with us. One is medical student, one is a pre-med student, and they will help us to a better understanding about the endocrinology section in MCAT, and also in medical school, how it will help us to learn about it. So as mentioned, endocrinology is the study of hormones, and basically is the endocrine system we have, and it's associated with the diseases. And hormone is basically a chemical release from one cell to another cell. So as Minal went over different organs of the hormone pretty quick, you can see in this diagram all the organs producing different hormones. And we will focus today about the pancreas. So pancreas plays a very vital role in our digestion. So it's basically located in our body, in our abdominal area, in an epigastric region behind our stomach. And it's about the size of our hand. It has a head, neck, body, tail, and uncinate process. So you can see in this diagram, this is the head, and this is the tail of the part that is going towards the spleen. So this head is in the C part of the duodenum. So during digestion part, our pancreas plays a vital role. It reduces the two types of enzymes called exocrine and endocrine. So exocrine secretions help with the digestion part, and the endocrine part we're going to talk about today is very important. So as mentioned, pancreas has dual roles, organ of digestive system and endocrine system. So exocrine pancreas may produce the hormone that help with the digestion part, for the digestion of our food, digest the food. particularly the proteins. And the endocrine pancreas produces the hormones, endocrine hormones like insulin, which helps to regulate our blood sugar levels in our body. So I will go over pretty quick the histology of the pancreas. And there's main types of tissue that make the pancreas are the acinar cells, the ductal cells, and the islet cells of Langerhans. So pretty quick about the islet cells of Langerhans is the endocrine portion of the pancreas that arrange discrete islet cells of Langerhans, which are composed of 5 different endocrine cell types. So most importantly, alpha cells, beta cells, delta cells, and epsilon and upsilon. So these are secreting at least 5 hormones, including glucagon, insulin, somatostatin, pancreatic polypeptide. So these are the hormones released from the islet cells of Langerhans. So basically, the endocrine pancreas makes hormone, including the insulin, glucagon. They are very important in the metabolism of our metabolism of glucose. So I hope the pre-med students have learned about in biochemistry about the glucose metabolism and the gluconeogenesis, glycolysis. So these are all hormones play a vital role as well. So important hormones basically they come directly into the bloodstream. And today we're going to talk about basically about the insulin, because we are talking about the diabetes, the most common condition we as a primary care physician, as endocrinologists deal with. So basically what happens, the insulin is the hormone that acts lower our blood sugar, helps to lower our blood sugar, and glucagon, which helps to raise the blood sugar. So pancreatic beta cells play the vital role in the glucose homeostasis by secreting the insulin. And this is the only hormone capable of lowering the blood glucose concentration. So briefly, I went over the anatomy and then the histology of the, please go over the next slide of the histology. Yeah, so you can see over here, the islet or Langerhans cells that produce the 5 different types of cells, and beta cells produce the insulin. So let's go over the case studies. So this is case studies. Any one of you can please volunteer and read this case study for me?
Yes, I can read it. Question 1. A 26-year-old woman has a 10-year history of type 1 diabetes mellitus. She has maintained strict glycemic control and has had no significant diabetic complications so far. On her last routine examination, her blood pressure is 125/78 milligrams of mercury. Blood chemistry studies are within normal limits. Fundoscopic examination of the eyes reveals no evidence of diabetic retinopathy. Which of the following is the most appropriate next step in management to prevent diabetic nephropathy?
Good. So what do you think? First of all, tell me what's going on. So this case study is telling us a patient has a type 1 diabetes. So they give you the blood pressure, they give you the chemistry within normal limits, they give you the eye exam via fundoscope examination, and there's no evidence of retinopathy because they're talking about the diabetes complications. So retinopathy is the complication of the diabetes. When patient has a long ongoing diabetes, then retinopathy develops. But they mentioned about yeah, so they're talking about the diabetic complications. So what do you think? They're talking about nephropathy. So what we can do to prevent the diabetic nephropathy? So what do you think we should do? Out of these 5 options, the periodic measurement of serum creatinine levels, screening of microalbuminuria with dipstick examination of the urine, screening of microalbuminuria with 24-hour urine collection, administration of ACE inhibitors, and renal biopsy. What do you think?
I think C.
Okay, yeah, good. So basically, what is diabetes? So diabetes is a disease in which the body's ability is to produce or respond to the hormone insulin we talk about is impaired. So what happens when it's impaired, there's resulting in the abnormal metabolism of carbohydrates. So insulin is very important for the metabolism of carbohydrates. And when there's impairment because of the production issue or response issue, so what happens? The elevated cause the glucose level to be elevated in the blood and in the urine. So yeah, correct answer is C. So diabetes mellitus is the most common cause of the chronic renal failure in the United States. And what happens is diabetic nephropathy is one of the most severe complications, and it manifests on average about 10 to 15 years after the onset of the diabetes. And the earliest expression of the diabetic nephropathy is the microalbuminuria. What does it mean? So it means that the kidneys start filtering the protein in the urea, and albumin is one of the part of the protein and called microalbuminuria that we see under the microscope. And while the patient is otherwise asymptomatic, so this is how we can screen early screening of the diabetic nephropathy by looking up the microalbuminuria. And this is the rationale of the for screening diabetic patient for microalbuminuria, which should be performed by 24-hour urine collection, or we can do an early morning urine sample as well. So that's the reason we have to do this test. So in the case the why not B answer? So basically the dipstick screening may not be sufficiently as sensitive as compared to 24-hour urine. That's the reason we have to go for the 24-hour urine screening, microalbumin urine test. And the albumin creatinine ratio in the early morning urine sample is a very convenient alternative we can do to 24-hour urine collection. And this is how we can figure out, we can screen. And during the phase of microalbuminuria, we can do the aggressive treatment. And how we can do that? We can have a strict glycemic control. Basically, we have to have a good diabetes control and blood pressure control in order to prevent the damage to the kidneys. And why not answer A? Because the measurement of serum creatinine levels would not be that valuable in detecting the preclinical renal damage. And the answer D, the treatment with the angiotensin converting enzyme inhibitors is shown to slow the progression of renal nephropathy, but because, first of all, we have to screen, but possibly because of the reduction of the intraglomerular pressure, it can be inaccurate. So this treatment is not widely used if microalbuminuria is absent. So there's no microalbuminuria, so we have to screen first. And when the patient is normotensive. So you can see in our case study, the patient is normotensive. And the last choice is renal biopsy. So renal biopsy is not indicated in the asymptomatic patients and in say asymptomatic diabetic patients. So that's is a method of prevention of the renal disease. So again, next you can see the basically microalbuminuria test we do to check, next please, to do the test. So we send the sample to the lab, they do analysis for the microalbuminuria, and this is how we can screen for the diabetic nephropathy. All right, so let's go talk about the case study number 2. Can you please volunteer to read it for me?
Yes. A 58-year-old man with a 12-year history of type 2 diabetes mellitus comes to the physician because of an ulcer in his right foot. Physical exam reveals a 1 centimeter irregular ulceration over the right metatarsal head, surrounded by an area of black gangrenous skin. The patient is admitted to the hospital and undergoes amputation of the right forefoot. Which of the following measures would have been most effective in preventing this complication? A. Appropriate instructions on self-care of the feet. B. Doppler examination of the lower extremities. C. Neurophysiologic and electromyographic studies. D. Local application of platelet-derived growth factor. Or E. Prophylactic treatment with cholesterol-lowering agents.
Right, thank you. So again, in this case study, we are talking about the complications with diabetes mellitus. So what do you think? What should we do? Based on this case study, patient is presenting, giving the story, giving the history about the ulceration. So what do you think? What should be the best answer to prevent the complications?
I think to prevent the complications, they should have been given more appropriate instructions on self-care of the feet.
Good, very good. Yes. So why do we need it? So again, as I mentioned, it's a complication of the diabetes, and the complication of diabetes effect include the heart disease. It can affect the kidneys, can cause a chronic kidney disease, and can cause a nerve damage. So in this scenario, case studies, there's a nerve damage, and it affect the hands, affect mostly the feet, because so that's why we have to be very careful and we counsel the patient, give the proper instructions to take care of the feet. How we can do that? Make sure, because sometimes we ignore our feet care, right? Or feet hygiene. So we have to educate the patient who has a diabetes to make sure to inspect their feet, make sure there's no wound. Sometimes because of neuropathy, they cannot feel the pain. So that's the reason we have to give the clear instructions to the patients for these. And I would like to share the diabetes has stages like pre-diabetes, the full-blown diabetes, and then the diabetes with the complications. So now we are talking about the diabetes, the complications. So that's the reason patients are particularly prone to gangrene of the feet when they ignore it, because after ulceration, what happens? Next step can go into gangrene. And sensory loss because of the neuropathy, because nerve to the damage and damage to the nerves due to called peripheral neuropathy, it affects the small vessel disease leading to ischemia as well. So that's the reason, and it can cause secondary infections. And it can be the underlying pathology. So we have to give the clear instruction to the patient who have diabetes to take good care of their feet. And as we mentioned, I would like to share, the diabetes is the leading cause of the non-traumatic amputations. So when you will be in clinical scenario, clinical setting, we see a lot of amputations. And because of the complications of diabetes, because they didn't good care of their feet, and they end up in the foot ulcer, they progress to the gangrene, and there's no option other than amputations. So that's why, and how we can improve prevent the neuropathy. So in addition to strict glycemic control to prevent the vascular damage and neurologic complications, the most effective method is the prevention. Prevention is better than cure, right? So prevention is a self-care. Give the clear instruction to the patient. And the answer B, why not the answer B? Because Doppler examination of the lower extremities assesses the vascular insufficiency. It can be arterial Doppler, it can be venous Doppler. And since the arteries may become rigid, may become affected because of the calcification or atherosclerosis, but they are falsely elevated, blood pressure reading may be obtained with the test. And why not the answer C, the periodic non-physiological and the electromyographic studies are not useful to prevent the foot complications in the setting of the neuropathies. And then the local application of the platelet-derived growth factor is not a right answer, because it has some efficacy in treating the non-healing ulcers refractory to debridement and antibiotic therapy. So first of all, we need to do the prevention. And then last but not least, why not E is not a correct answer, because prophylactic treatment with cholesterol-lowering agents should be considered, should be added, because it helps with the risk factor of the cardiac disease when we add on the cholesterol-lowering agents like statin, atorvastatin, other class drugs. So should be considered in a patient who have diabetes with high cholesterol level to prevent or slow the atherosclerotic process. So again, I can show you this diagram. This is a neuropathy. You can see there's a damage. There's how the normal nerve look like and the damaged nerves look like. And so basically, neuropathy is the damage to the peripheral nerves are damaged, and we can prevent by giving the clear instruction to the patients. And basically, this condition causes the weakness, numbness, and usually some patients have the neuropathic pain as well in hands and feet. With the patient with the chronic diabetes lasting for 10 to 15 years. So let's talk about another case study. So can you please read it again for me?
Yes, an 18-year-old Caucasian woman presents to her physician with complaints of excessive thirst over the past several months. Dipstick urinalysis demonstrates 4 plus glucose in the urine. Blood chemistries demonstrate a glucose level of 420 milligrams per deciliter. In Caucasian patients, the condition affecting this woman is most strongly associated with which of the following HLA types?
All right, good. So they're talking about the HLA types. What is HLA? So basically, HLA is a human leukocyte antigen. And in this scenario, they talk about the patient has a diabetic ketoacidosis. So diabetic ketoacidosis is a complication for the type 1 diabetes in the patient who has a type 1 diabetes. So you can see the young patient, 18-year-old, presenting with all these, you can see chemistry, how high sugar glucose level is, So this is they're asking about the HLA types. So HLA types, as we talk about, human leukocyte antigen is associated with the type 1 diabetes. And the correct answer is HLA DR3 and DR4. So basically, this is a typical presentation of type 1 diabetes mellitus. You can see the young patient and typically diagnosed in childhood or during the adolescent. And this form of diabetes is most prevalent in patient type younger than 30 years of age. And type 1 diabetes patients are particularly prone to develop the diabetic ketoacidosis called DKA. And it's a medical emergency. We treat those patients in the close observation in ICU units, and they produce what happens in their scenario. In these patients, they produce very little or no insulin at all. And there's a strong association between the type 1 diabetes and specific HLA phenotype DR3 and DR4. So DR3 and DR4 is the right answer in this scenario. Other are not related to type 1 diabetes. So let's go over. So now you have to, you can see in this diagram, this is a cell. So this is how basically HLA are the proteins or the markers on most of the cells in our body. And our immune system uses these HLA to see which cells belong in our body and which do not. So that's the importance of these HLA antigens, human leukocyte antigens. All right, so let's go over the case study for next case study, please. Can you read it for me?
A 45-year-old woman presents to clinic for a health maintenance visit. She has no complaints but has a history of diabetes and a family history of hypertension. On physical exam, the patient's blood pressure is 150 over 100 milligram mercury. The laboratory results are normal. Which of the following agents would be most appropriate for the management of her hypertension? A, atenolol, B, captopril, C, furosemide, D, hydrochlorothiazide, or E, isordil.
Good. So in this case study, they are asking about the patient who has diabetes and hypertension. So how we will treat the patient. So these are all the different drug classes to treat the hypertension. So which medicine we are supposed to pick up, because these all can treat the hypertension, right? So we have to give the rationale why we are answering one. So answer in this, first of all, I will go over angiotensin converting enzyme. What is angiotensin converting enzyme? So basically, it's a key component of the renin-angiotensin system. Most of you had read in the pre-med during your biochemistry classes about what is renin-angiotensin system and angiotensin converting enzyme. So basically, answer in this scenario is the B, the captopril. It's called angiotensin converting enzyme inhibitor. So as I mentioned, angiotensin converting enzyme is a key component of the renin-angiotensin system, which controls our blood pressure by regulating the volume of the fluids in our body, and it converts the hormone angiotensin 1 to the active angiotensin 2. So and angiotensin 2 is a vasoconstrictor. So in this scenario, we have to pick the angiotensin converting enzyme inhibitors. Why? Because they block that enzyme to convert angiotensin 1 to angiotensin 2. So captopril is one of the drug class for the angiotensin converting enzyme inhibitor, and it helps in cardiac remodeling in the patients who has diabetes. And high dose of angiotensin converting enzyme inhibitors have been shown to have a mortality benefit in hypertensive patients. So all the other medications are very good hypertensive alternatives, agents to help control the blood pressure, but captopril is the most effective in patient who has a diabetes. So angiotensin converting enzyme inhibitors also have a protective effect on the kidneys in patients who have diabetes by inhibiting the actions of angiotensin 2 on the renal efferent arterioles, and by attenuating the stimulatory effect of angiotensin 2 on the glomerular cell growth. And you can see in this diagram as well. And there's a mesangial matrix production. And of course, creatinine were very high, and indicating the renal insufficient in this patient. So we should choose the most effective agent in patients who have diabetes and who have the hypertension as well. So angiotensin converting enzyme inhibitors, and you can see in this very good diagram how this enzyme released from this angiotensin converting enzyme change from angiotensin 1 to angiotensin 2, how it affects on the kidneys glomerular filtration system, and how it will help to inhibit this enzyme to control the blood pressure in patient who has a diabetes. So next option, the choice A, the atenolol. So atenolol is a beta blocker. And we give this drug in the patient with a coronary artery disease. And the beta blocker is a reduce the mortality in patients by decreasing the chronotrophy, and because it reduces the contraction of the, it helps with the reduces the contraction of the heart muscles and exerting the protective effect. And furosemide choice C is a loop diuretic. It's also called the Lasix. It's used as a diuretic when patient need to be diuresed, when patient is a fluid overload, like a patient with congestive heart failure. So we give the Lasix in those patients. And next option was the hydrochlorothiazide. So hydrochlorothiazide is a class of drugs, another diuretic agent. It's useful in the management of hypertension. We give especially in the African Americans patient. And isordal, given it belongs to the nitrate family of the vasodilators, and it affects the vasodilator effect that decreases the preload of the heart, preload effect. So it's used as an adjunct of the first type therapy in hypertension with who has a coronary artery disease. So as you learn about the angiotensin converting enzyme in your pre-med, and we have a pre-med student, we have Amna with us, and she can tell us about this biochemistry, how much important is the MCAT exam. And so we have to be, while we learn about this, so you learn why we are learning these concepts. Okay, so now let's move on to our next case study. We have a pre-med student with us as well. Can you please read this for us?
Yes, sorry about that. Okay, so case study number 5, a confused elderly man is taken to the emergency department. The patient was found wandering and complaining of severe abdominal pain, but is unable to give a coherent history. Urine dipstick demonstrates positive ketones, but no glucoseuria. Stat blood chemistries show a plasma glucose of 100 milligrams per deciliter. Which of the following is the most likely explanation for these findings?
Okay, good. So now in this scenario, patient is, as we talk about in type 1 diabetes mellitus, patient has a diabetic ketoacidosis. So now in this scenario, we can see the patient presenting with the same high glucose levels. And let's see, no, sorry, not high glucose levels. Patient has a positive ketones. So this patient has going in the DKA, diabetic ketoacidosis. So they're asking, what do we think these conditions, alcoholism, congestive heart failure, emphysema, inflammatory bowel disease, rheumatoid arthritis. So which of these conditions can cause patient to go into the diabetic ketoacidosis patient who already has a diabetes? So what do you think, Amna? Just give educational guess. Okay, so there's no wrong and right answer. So I would say in this scenario, it's the alcoholism. So we should be aware of that. Ketoacidosis can be seen in the conditions other than diabetes mellitus. And the two most important are the starvation and chronic alcoholism. So the mechanism of ketone production in chronic alcoholics appears to be a combination of alcohol withdrawal and starvation with increased free fatty acid release. And most of you are learning in your biochemistry section, the pre-med courses about free fatty acid metabolism and free fatty acid in your biochemistry classes. And the typical history is very important to know about it. And like we can ask about social history. In social history, we ask about the alcoholic use, how much drinks they are using, and this it can help us. And this patient, the patient present with the abdominal pain is a prominent complaint, and also patients have pancreatitis. And what happens when patient have use too much use of alcohol causes pancreatitis and can impair the glucose tolerance. And even the mild type of diabetes mellitus or pre-diabetes, patient who has a pre-diabetes often demonstrated after the patient recovered from their acute episode. So other option, congestive heart failure, emphysema, rheumatoid arthritis do not cause the non-diabetic ketoacidosis. Okay, all right. So let's pretty talk about the alcoholism. So alcoholism is basically what is that? It's the inability to control drinking. It's excessive use of alcoholism and due to both physical and emotional dependence on the alcohol. And symptoms include strong need or strong urge to use alcohol. And those with the alcohol use disorders uh, have problems controlling drinking, and they keep drinking, continue using the alcohol, and cause a problem. So then if this when they stop drinking, there's alcohol withdrawal. And so how we can do it, how we can manage these patients. So treatment involves the counseling of the patient, such as behavioral therapy can help. There are some medications. I will not go over in detail for that. And of course, behavior modification is very important to help these patients. And sometimes we need a medical detoxification to stop drinking safely. And of course, patient need moral support. There's support groups available to help them stop drinking, and they can manage the relapse and cope with the necessary lifestyle changes. So let's move on to our next case studies.
Okay, I'll read it. So case study number 6, a 22-year-old woman with type 1 diabetes mellitus presents to the emergency department with anorexia, nausea, vomiting, and abdominal pain. She's recovering from pneumonia and has had much difficulty regulating her blood sugars lately. On arrival to the emergency department, her blood glucose is 760 milligrams per deciliter. Sodium is 125, potassium is 3.0, bicarbonate is 12, chloride is 92, and her blood is positive for ketones by acetone screening. Which of the following is the most appropriate initial step in management?
Okay, good. So you have to focus the last line. Which of the following is the most appropriate initial step in management? So all the options can be right, not in this scenario, I would say. But they're asking the initial step we are supposed to manage the patient. So first of all, we need to diagnose, right? Again, a young patient, a patient has history of diabetes mellitus. They're giving us the glucose level is way above high 700 plus. So we have to see what's going on. So now they also mentioned positive for ketones. So as we talk about the diabetic ketoacidosis, so now we have to do the management. How we will manage the patient who are going into ketoacidosis. So as I mentioned, these are very important to manage the DKA. So we've admitted the patient in the ICU. So we close monitoring. We have the sugar levels to be checked more frequently. So answer is E, is the IV normal saline. Is a 0.9% normal saline we hydrate. Why? So the management of the diabetic ketoacidosis requires basic understanding of three concepts. So what are those concepts? First of all, we need to find out the underlying trigger for the DKA, why a patient has it. And then the patient is very volume depleted. Patient is dehydrated, and patient has severe electrolyte abnormalities as well. So the management, therefore, should be focused. The initial step should be focused, and also the patient has anion gap, patient has an elevated blood sugar level. So the first step, the initial step to care for all the patients who has diabetic ketoacidosis should be prompt restoration of the volume status. So how we can do that? By assessing the IV line and start the IV fluids hydration with the normal saline. And this is the number one priority to build up to restore their volume status. So other options like giving the antibiotic therapy, is it appropriate when there's underlying infection? So of course, however, this intervention has no place in acute bench of DKA. So we have to first of all restore their volume status, and then after that we can administer the IV glucose insulin choice B is appropriate once the blood glucose level is below 250 milligram per deciliter. And this is how we give, then at that time we can give. And then why not hypertonic saline? Because it should not be administered since the patient corrected sodium is 133. So within normal range, so we don't need to give it at this time. And then administration of IV potassium, why we need it? So it can be needed as the patient's acidosis begins to correct and the serum potassium levels start to decline. So in diabetic ketoacidosis patients, the total body potassium becomes depleted as a result of diuresis, as when we give the patient diuretics. So we can replete, but first initial step is the IV hydration with the normal saline or any fluid we have available. All right, so let's move on to the next case study.
Yes, so case study number 7. 1 week following an uncomplicated delivery, a 27-year-old woman comes to the physician because of polyuria and excessive thirst. Her pregnancy was normal, but she reports that she began to feel an unusual craving for ice water in the last month of gestation. She is forced to get up at night several times to void and drinks large amounts of water. Her blood pressure is 120/80 milligrams of mercury. Serum electrolytes are within normal limits. A 24-hour urine collection during ad libitum water intake yields the following results. Total volume 10 liters, specific gravity less than 1.006, glucose absent, protein less than 150 milligrams. Which of the following is the most appropriate next step in management?
All right, good. Thank you. So, right. So first of all, we need to diagnose what's going on. What's the diagnosis? So based on this case study, patient has diabetes insipidus. So we talk about diabetes mellitus, and now we're talking about the diabetes insipidus. So basically, it's a very it's an uncommon condition in which the kidneys are unable to prevent the excretion of water, and basically, it's a condition marked by the patient present with the increased thirst and increased urinary frequency, increased urination. So a correct answer in this scenario is that patient has a correct answer is B. This patient is highly suggestive of the diabetes insipidus, and basically it's a disorder due to the deficiency of ADH. What is ADH? It's an antidiuretic hormone. So antidiuretic hormone basically helps blood vessels to constrict, and it helps the kidneys control the amount of water and salt in the body. And this helps control the blood pressure and amount of the urine that is produced. So what stimulates the ADH to be released? So basically, it's when there's an increased osmolarity in the blood. This is the trigger to promote the hypothalamus in our brain to release the ADH, antidiuretic hormone, which signals the cells in the kidney, in the kidney tubules, to reabsorb more water by inserting aquaferins, thus preventing the additional fluid loss in the urine. So there's B is a correct answer due to deficiency of the antidiuretic hormone secretion from the posterior pituitary gland. So ADH is produced from the posterior pituitary gland, and the polydipsia is a consequence of the polyuria. It's not an effect because there's an abundant diuresis going on secondary to the ADH deficiency. So that's the reason. And the answer is the vasopressin challenge test is given by administering the desmopressin. So what is desmopressin? Desmopressin basically is a synthetic form that is given by the nasal route, and we monitor the unit output for next 12 hours before and after administration. And if patient is symptoms is due to the central diabetes insipidus, the patient will experience an immediate reduction in the thirst and urine output. And diabetes insipidus may manifest in the third trimester of pregnancy, like in our case study, or during the purpurium because of the circulating enzymes called vasopressinase that degrades the vasopressin in our body. So the enzyme is not effective against desmopressin, so that disorder resolves spontaneously. And the option A is not because less likely, because the high likelihood of non-compliance advising the patient to reduce water intake would expose her to severe dehydration and can cause hyponatremia due to loss of the water and result in the hemoconcentration. So that's why it's not the choice is not right option. And why not choice C? Because the MRI studies of the pituitary hypothalamic region are performed to search for the mass lesions. And it may be the underlying cause of central diabetes insipidus, but these investigations should be performed after the diagnosis has received confirmation by the vasopressin challenge test. And then compulsive water drinking may require the psychiatric evaluation and maybe make the diabetes insipidus. Sometimes those scenarios we can see as well in a real clinical setting, but this possibility should be undertaken once diabetes insipidus has been ruled out. When we say this challenge test is normal, then we can think on other differential diagnosis. So in this particular case, the close temporal association with the pregnancy and delivery makes the diagnosis of diabetes insipidus more likely. And the choice E, So evaluation of the nephrogenic diabetes insipidus is the next appropriate step if the patient does not respond to the vasopressin challenge test. So, as diabetes insipidus central or nephrogenic. So nephrogenic diabetes insipidus is in fact due to the resistance to the renal tubules to the action of the vasopressin. And basically it's a hereditary X-linked form of disease and usually associated with the hyperuricemia as well.
It's 11 o'clock.
So in this diagram, you can see the ADH, how it released from the brain and then from the posterior pituitary gland. And also it increase in the osmolarity of the blood cause the trigger, and that causes the ADH to produce, and we signal the cells in the kidney tubules, you can see in this diagram, to reabsorb more water by and thus preventing the additional fluid loss in the urine. So let's go over quick about the risk factor for the diabetes mellitus. So risk factors are the high cholesterol level can causes, impaired glucose tolerance, then older age older than 35 years can cause it, and then the diabetes mellitus, overweight can cause a risk of diabetes mellitus, heart disease, and stroke. So, and also the when there's a obesity, overweight can cause high blood pressure. So these are, I want to talk about briefly about preventive medicine. So how we can prevent the diabetes mellitus, right? We talk about the risk factors. So all the factors causing the diabetes, we have to control those factors to prevent the diabetes mellitus. So what is the preventive medicine? So preventive medicine is basically the practice of promoting the preventive healthcare to improve the patient's well-being. And the goal is basically to prevent the diseases, prevent the disabilities, to reduce the morbidities and mortalities. And it's equivalent is a lifestyle modification, medicine concept is also introduced, and is basically the medical approach that uses the evidence-based behavioral interventions to prevent the disease, to treat the disease, and to manage the chronic diseases. And so these are the basically and how we can achieve those, again, by the healthy lifestyle. As we talk about self-care, we talk about how we can do that by healthy nutrition, plant-based nutrition, physical activity on daily basis, stress management, avoidance of the risky substances. We have to, our sleep hygiene, we can do that, our social interactions, our social health, these are all can help us. So preventive programs are basically aimed at reducing the likelihood that a disease develops or worsens. So preventive program can be divided into different three types, you can say: primary, secondary, tertiary. So primary prevention attempts to prevent the disease before it develops. How we can do that? As I mentioned, lifestyle modification, right? And examples of a primary prevention include all those programs aimed at reducing the risk of specific diseases. Avoidance of cigarette smoking can prevent the lung cancer, cardiovascular disease, immunization reduce the risk of infectious diseases, as we had just have gone through the COVID pandemic. So now thankfully, we have the immunizations available for COVID. So now this is all the primary prevention. And so primary prevention basically is more effective than the individual-based approach. And of course, like obesity, how we can do that: regular exercises, our dietary habits. So this is how we can prevent obesity, and then the risk factor for diabetes, cardiovascular disease, or stroke. And secondary prevention is based on the early detection of the existing pathological state before it causes damage to the organism, before it causes or damage to the organ system. So examples can be following the annual mammograms for women, then detect the breast cancer in early stages. We can do controlling the hypertension by lowering the cholesterol level, by having healthy dietary habits, preventing obesity by having nutritious, healthy dietary habits. And also we can manage the lower cholesterol levels to prevent, reduce atherosclerotic diseases. And then pap smear screening, then colonoscopy. So these all come in the secondary prevention. So tertiary prevention is based on basically the rehabilitative interventions or the methods that improve the clinical evolution of a disease that has already been developed. So like we can use the prophylactic, use the aspirin after having myocardial infarction. We can is a classic example of the tertiary prevention. So I will stop here now. So basically all the lifestyle modification, lifestyle medicine, preventive medicine, these all talk about for our healthy lifestyle living. And all, you know, in all my sessions, I bring up all about the self-care, what is well-being. Again, I talk about these 4 areas: physical health, spiritual health, emotional health, and our intellectual health, our mental health. So these are very important. And physical health, I say, take care of the sleep hygiene, your exercise on daily basis, your learn how to manage the stress and the food, nutritious food, healthy dietary habits. And why we talk about self-care every time. So self-care, if we are not healthy, like God forbid, if I'm not in a good shape today, if I'm feeling sick today, I will not be able to help you guys, right? Because I'm sick, I'm not taking care of myself. So there's a reason we cannot give it to others but we don't have. So please make a habit to have a self-care. So it's very important for your well-being as well. You are the vital part of the society. You have when you are healthy, then you will your community around you will be healthy. You will try help other people as well. So there's the reason I always talk about the self-care and well-being. So again, and last but not least, the how we all want to be success in our life, right? We all want to achieve our goals. So everyone has their own definition of success. And every time I try to talk about some good books, today I would like to talk about a 5 a.m. club, or you can call it the morning club. So make a habit of early waking up, go for exercise, make your plan for the day. So that's very important to learn. So we all are responsible to hold our future, and we take a responsibility to hold our future in our own hands. So success means we need to be disciplined ourselves. Our sleep, as I talk about during self-care, our sleep hygiene, our morning club time, our to discipline ourselves to achieve our goals. So I would like to share, like, waking up early is truly like the mother of all routines. And eventually, when we are, I always say we are habit, we are the creatures of our habits. So these are all the habits we have to adapt to be successful in our life. And always these 3 Ps you can see over here. So eventually success comes when we have a good habits in our life, we follow our routines, and we find a purpose in our life. So what the purpose of all our work should be, what the productivity and accomplishment, right? We feel so good when you accomplish our goals. So how we can achieve those? So follow these 3 Ps and make good habits. And always say your passion and profession should be the same. It's a very rewarding profession, and I feel so blessed to have this profession. If someone asks me if you want to start again, I would say I will definitely like to go back in medicine again. Of course, a lot of sacrifices, a lot of hard work, a lot of efforts, a lot of failures as well. But again, at the end, it's very rewarding profession, and we all sometimes feel down, and we all face a failure. But failure is the first attempt in learning. So always feel whenever we have setbacks in our life, just take some time off, think about it, what happened, how you can start again. And if you're really passionate about it, you can do it. And take small baby steps and be persistent, and you will achieve your goals. And of course, with your persistent performance, you will give the results and you will feel good about it. So I will stop here. Thank you everyone for joining, and thank you everyone. Keep it up. You are future healthcare providers, healthcare physicians who can help our community, who can help in broad term worldwide. We can help humanity and start paying back to the community from now, even small baby steps. Thank you, everyone. I wish you all good, best of luck. Thank you.
Yeah, thank you so much, Dr. Chima and Manahil, for this incredibly informative session today. I know I learned a lot about endocrinology, hormones. We went into all the tiny details. Thank you so much. So our quiz is now on our website at teleshadowing.com/certification. Again, you'll need a 70% or higher to receive the certificate for today's session. And our next session will be on April 20th, Saturday, April 20th at 9 a.m. Eastern Standard Time. So there's no session on the weekend of April 13th. Thank you all so much for tuning in, and I hope to see you all next time. Thank you.